Hello, everybody. My name is Max Knight. I'm a licensed and certified athletic trainer. I'm currently a student at Indiana State University in the Doctorate in Athletic Training program, part of the 2020 cohort. Today, I'll be talking about disablement models, as well as kind of integrating a patient scenario, such as tendonitis, to kind of make things a little cohesive and relatable for you. So right away, we're going to get into the Nagi disabled model. It's one of the first models created, and I really appreciate this model because I think it is a great representation of patient-centered care, kind of like holistic care. So again, during the 1960s, Nagy created a model that addressed complex literature on disability. Was a little confused on what it was. He was kind of able to focus in on patient's disablement and kind of address physical limitations, but also dive in and let clinicians see other aspects of patients' life, kind of integrating that patient-centered care. So there are 4 different dimensions. The first one's active pathology. So this, like it says, focuses on the cellular level, such as damage to body structures. So in this scenario, it would be micro tears and the patella. Now going into impairment, the second dimension, this is going to be impairment of body systems. So there's going to be decreased quad strength for that patient scenario. Then the third one, there's a functional limitation. And in this level of disablement, it's going to focus on the whole person. So in this scenario, the patient's not going to be able to decelerate from sprinting at 60% max effort. They're going to have a lot of difficulty doing this. It's going to be painful, something they will try not to do. And then the fourth one is the disablement, level of disablement. And this is going to focus on kind of societal roles within the patient's life. So in this case, the patient is unable to fulfill their role as a starting center on their basketball team for his senior year. So he won't be able to play that role within his basketball society, and the society kind of surrounding him, fans, the culture of that. So those are the 4 dimensions of the Nagy disablement model. So now we're going to get into the NCMRR disablement model. This was kind of based off of Nagy's model with the addition of one more dimension. So again, this is the National Center for Medical Rehabilitation Research model. Focuses on enhancing the quality of life for patients with disabilities research. And again, the 5th dimension, one that they just kind of added on top of Nagy's model, is a societal limitation. We'll kind of get into that here in a second. So first of all, there's the pathophysiology. Going to focus just on the cellular component of the patient. So again, we have micro tears and the patella tendon. Next, we have impairment. Again, it's going to be focused on body systems. Again, the patient's going to have decreased quadriceps. Next, we have functional limitations, and again, it's going to be kind of based on the whole person. And then again, in this case, they're going to be unable to decelerate from a 60% max. Then again, getting into disability, this is where the Nagy model stops. It's going to end right here. And again, we're going to have a relation from person to society. And again, in this scenario, they're going to be unable to be the starting center for the school basketball team, unable to fulfill that role. And then we go into societal limitation. And this is kind of restrictive barriers, limitations that won't allow them to fulfill their role in their society. Um, so again, in our scenario here, uh, the patient could potentially lose their athletic scholarship, and ultimately restricting them from being a part of the team or even playing basketball or maybe even uh, being associated with school. So it's a whole another level that kind of makes the clinician think about how there are other aspects kind of affecting this person. So now we're going to get into the World Health Organization's International Classification of Functioning, the ICF, disablement model. It uses a coding system just like the ICD-10, and it's kind of designated to differentiate different domains throughout this model. It's a little different from the first two, and we're going to see here. Um, so the difference here between the first two is that this model uses its own coding system, like I said before, for classifying disabilities. This model has two parts. The first part is a health condition, so that'll be patellar or tendonitis. The next section is going to be body functions and structures. So body function is going to be more like decreased quadricep strength, while structures is going to be micro tears within the patellar tendon. Activity, that's going to be, just saying this person has, mild difficulties. If you're difficulty walking, running, jogging, going up and down stairs, that kind of thing. And then there's participation, which kind of focuses more on the sport, while activity is more kind of outside the sport, just daily living, their health related quality of life. So for participation, they're gonna have a running limitation and a difficulty decelerating strength event. Part two, there's going to be environmental factors. So there could be an athletic trainer that's currently, providing them with modalities, exercises, just kind of facilitating um, excuse me, just kind of letting the athlete participate in the sport and still be involved. Um, Whether that be putting in a little bit of time in practice, still getting them to be able to be on the court during games. Um, and then there's the personal factor, which is having experience with patellar tendonitis before, being a senior in college, and kind of been going through a lot of trials and tribulations as far as injury go. And that can also lead to like coping mechanisms and realms. So what do the codes mean? So again, we have our two parts here for the ICF codes. Body functions start with B, and we have one qualifier. The qualifier simply means it's just the extent of impairment. So kind of showing how severe it is. It goes from 0, from not severe, to 4, being very severe. And then the structures, that code starts with an S and has two qualifiers. The qualifiers for that is, again, the extent of impairment, and then the second one is the nature of structural change. So, like that code could be, or that number could be for micro tears or inflammation in there, something around that realm that changes the structure of that. And then we're going to go into activity. This code begins with D. This one has one qualifier. It's the amount of participation restriction. So, you know, are they able to walk around for extended amount of time, building on stairs, um, things along that realm outside of the sport. There's participation, which has two codes, also begins with D. Again, the same as number one, and then there's also number two, the second qualifier, the extent of activity over patients without assistance. So being able to run up and down the court, being able to jump without like assistive devices, or having someone guide them through like their range of motion, or things like that. And then there's part two, environmental factors. This code begins with E. Um, and then there's personal factors. That one doesn't really have a code because it's really coded. So those are the three main disablement models. And what I love about these is that you can see over time, from the 60s, the 80s, 90s, early 2000s, that people really started to look into the patient's health-related quality of life. And you can really see that through, the societal limitations and societal roles. Like, is the patient going to be able to, still have their athletic identity? Are they going to be able to function, without that? If the injury is serious enough to, not let them play anymore. So it's really important for, especially us as athletic trainers to kind of start working our mindset towards that, and kind of almost trying to figure out a way to, look at a patient using, a disablement model, anyone that you like. Kind of moving on here, we're going to go on our risk factors for sports injury. This is, being able to identify risk factors for your patient population, whether that's, you're working at a high school with soccer, baseball, football, or at a university where you're just in charge of soccer or basketball. So kind of being aware of these risk factors are able to mitigate injuries. So I'm going to go into the type of risk factors here. You have intrinsic and extrinsic risk factors. They're going to both be modifiable and non-modifiable. So here we see intrinsically modifiable ones are body composition, strength, flexibility, skill, fitness level. Those are all things you can work on and change over time. And then we have non-modifiable demographics. You're going to, there's age, there's gender, there's, lots of other things within that that you're not going to be able to change, or you can't change, someone's age, although it does change, every year, but you can't go back there. And then you have anatomy. Some people will be shorter, taller, and you may have discrepancies there. Then there's extrinsic risk factors, which modifiable ones, whether you can go inside, go outside, the playing surface, turf, grass, orthopedic devices, ankle braces, tennis straps, and then rules. And the idea of modify the rules if you can. And then there's non-modifiable risk factors such as lack of controlled activities, such as participating in games, having teammates around, opponents, things that can change the circumstances and so on. So now moving into types of risk factors within our patient scenario here. So if we're looking at a basketball athlete, modifiable intrinsic factors could be body composition. Maybe the athlete is a little overweight, and that's causing stress on him when he's running. Maybe the amount of forces from this composition causing a lot of strain on his tendon. There could be a lack of eccentric strength in the quadriceps, leading to impairment with decelerating from sprinting up and down the court, like fitness level, things like that. Non-modifiable ones, again, will be the demographics, how tall they are, how old they are, and ultimately their biomechanics. They may have um, some biomechanical issues that may predispose them to having patella tendonitis. There's extrinsic factors, which is again modifiable ones is controlling what they do in the weight room, what they do at practice, and maybe giving them a patella tendon strap to relieve that tension and that pain, so they can have maybe a higher pain tolerance when sprinting and decelerating. And then non-modifiable ones such as playing surface. I mean, basketball players who play at at university, you're gonna have to play on a court, you have to play on concrete, like that. Teammates, again, and then games, things you can't really control. And of course, whether if they're walking from their dorm to the field house or to practice, they may slip on some ice or things like that. This is external factors that you may not notice or think about. Next, we have injury prevention. So there are 3 steps to approach injury prevention. One, acknowledging your intrinsic, extrinsic factors within your population, your patient population. Knowing, if a 20-year-old male is going to be more prone to spraining his ankle or having tendonitis playing basketball compared to the females or things along that realm. Understanding injury rates using athlete exposures. You want to know if morning practices or afternoon practices are going to cause higher injury rates per 1,000 athlete exposures, or traveling to different locations for games. Maybe there's a playing surface there that causes more injuries per athlete exposure. So those are kind of good things to look into. And then using the TRIP method, kind of looking at these athlete exposures, knowing your intrinsic, extrinsic risk factors, looking into the research, seeing if there have been any strategies put in place, seeing if these strategies and prevention protocols have been tested in the lab in very controlled facilities, looking at randomized control trials and seeing if people were able to take the high efficacy and test the effectiveness of them in the real world. Being able to use the research and able to implement your own or their own preventive protocols and seeing if it actually works, analyzing if that's going to work, and if the players, the coaches, the university staff are going to buy into it and provide you the money, the equipment to facilitate that preventive protocol. And then again, the TRIP method, I kind of just expressed that here. There we go. So again, right away, we have our injury surveillance. We're going to look at your athlete exposures, things going wrong, seeing what time of day people are more prone to get hurt, where there's different regions people are more prone to get hurt, there's different populations, patient populations that are more prone to get hurt during certain events. If they're going to have more injuries over time. And then we have understanding the mechanism, kind of learning about why the injury happens or where it comes from. And then create preventive measures, like I said, looking at strategies people have come up with, and then kind of looking into the next one, testing your measures, so seeing if people have taken those strategies and done randomized control trials on them. And then, number 5, getting the athletes, the coaches on board, getting the money um, to test this out and see if it's effective in your own setting. Um, Evaluating the behaviors of athletes and seeing if they're going to be more likely to, incorporate this change, and then evaluating the effectiveness of your measures that you implemented and seeing if they're actually working and actually preventing. Okay. So now we're going to put it all together. We're going to understand just kind of quickly how to create a disablement model, analyzing health-related quality of life through disablement models, and PROs, and then identifying risk factors that can improve the disablement model dimensions. So improving someone's health-related quality of life. So we're going to use the NCMRR model. I personally like this one just because it involves that societal limitation to step above the NAGI model. I personally support more. So again, we have the pathophysiology that's on a cellular level, and that's involved microtears of the tendon. The impairment with the body system is decreased quad strength, the quadriceps. The functional limitation focused on the whole person is going to be their inability to decelerate from, let's say now, 80% max effort sprint, and maybe even have reduced knee range of motion. Maybe because it just hurts for them to flex and extend their knee. And then we go on to disability, the patient relation to society. They're unable to fulfill their role as a starting senior center for their basketball team, and then they have a loss of identity. They may lose their athletic identity, and that's important to know. And that kind of starts getting into the health-related quality of life. Maybe they're going to start struggling mentally. They're not going to be able to perform better that way. And then we have societal limitations, the barriers, risk of losing a scholarship, the risk of not being able to play basketball, and possibly, the risk of not being able to go to school anymore, just because, you don't have that scholarship. You're not able to be a part, of that society. So right there, we quickly saw that, there are other factors outside of this person's injury that are out that can ultimately affect their severity of their injury. Maybe this stress is going to make their injury worse, or maybe prolong it, or maybe it's going to reduce their motivation to do rehab. So it's good to know these factors because they also play into the clinician's ability to get the athlete the best possible care. Now going into risk factors in this scenario, our intrinsic ones, we can modify body composition. We can look at it. We can eccentrically strengthen the quadriceps and hopefully reduce our symptoms from the tendinopathy. We can stretch our hamstrings, stretch our quads, make sure we're still maintaining our fitness level. And so now we're moving on to non-modifiable ones. Again, we have our age, sex, height, maybe core biomechanics that we need to know of, and then we have previous damage overviews. I included both of these because with previous damage, there's nothing you can really do about it, but there actually is, and you can do preventative rehabilitative exercises, which is something that you can modify. Then we have our intrinsic factors. We're going to control the weight room activities. We're going to control the good practice. You could possibly get them on and monitor if we're overtraining or if we're overtraining during the summer. And the non-modifiable ones, playing surface, basketball players going to play a basketball court. Teammates, you don't know if they're going to bump into them or anything chaotic like that. That can happen in practice or with games with opponents. And then again, overtraining. Maybe we overtrain, in the summer and the beginning of the season, and that's kind of where we're at now. We're paying for it. So good to know those. And again, that plays into our health-related quality of life. Knowing those non-modifiable intrinsic and extrinsic risk factors can ultimately, shed light on the issue of why they're in their current state of health. And now, kind of going to injury prevention. Again, we got to know our intrinsic, extrinsic factors. We have to understand our injury rates by using athlete exposure. So, our population is basketball, collegiate basketball athletes. So we're going to look into, how many athlete exposures of increased injury rates having practice in the morning or in the afternoon, or how many days a week, or having practice for 2 hours compared to 1 hour. Things along those lines, using the trip method, using the research, seeing what the best protocols are out there, and then recording patient rated outcomes. So that'll also kind of look into the health and quality of life. You can see how the injuries affecting them outside of their athletic persona. Can they walk up and down stairs? Can they get out of the car? Can they stand up and make dinner and things like that? Can they sit down? Can they sleep? So those are all really good things to know, and it kind of all comes together for that full holistic patient-centered care. And then these are my references. Again, disablement models, they really reinforce patient-centered care. And I believe, the use of any of these models and the TRIP method and, patient-rated outcomes will really reinforce, patient-centered care and ultimately make us better clinicians because we are, not focusing or being minded on someone's physical limitations. So there's so many aspects outside of that is also affecting them too. So thank you for watching this.